All right, welcome back. Welcome back to the fourth and final day of our national conference. It's my pleasure to welcome back the former head of the Office of National Coordinator and the current Chief Clinical Officer for Verily Health Platforms, Dr. Vindell Washington.
Thanks. I appreciate the opportunity to talk with you guys today. I'll start with a little bit of a disclaimer. The way the name of the lecture is slated, it implies that there is a significant difference between this framework of health equity and clinical quality of care, or AI, or the tools that we use for care. And I'll just tell you that my bias is that there is no real distance, or at least there shouldn't be any real distance between the two. That's odd also because my title is a split title. I'm Chief Clinical Officer and also have a title as Head of the Director of Health Equity. But I'll try to convince you in the course of this discussion that in order to do both discovery and research well, and to achieve the clinical outcomes that you choose, that you cannot ignore a framework of health equity as you do the work. So the way that this will go, or at least I'd planned for the discussion to go, is I'll spend a little time talking about who Verily is. It's often a little bit of a question mark for folks. What problem it is that we're going to talk about and try to solve. I want to dive then down to what I think are the right kinds of tactics and tools and approaches that are likely to be successful, and then just end with a few examples of those principles put into motion. There's nothing I like worse that I feel it's a worse effort than to talk about this area in general of health equity and sort of platitudes and high discussion points without real action or on the ground activities that really lead or drive to something that's valuable. So on the who is Verily perspective, Verily Life Sciences has three main pillars: supporting research, driving direct care mostly in population health management, and sort of financing some of that work. And so where do we come from? We were a spinoff of Google. There was a lot of, at the time when Google became Alphabet, and many bets were made across many industries, healthcare was one of the bets. And so Verily is born out of that structure. And it's really this idea of putting together clinical expertise, technical expertise, data science, AI, and machine learning to drive solutions for some of the more gnarly or complex problems that exist in the world in which we live. And the focus that I'm sort of particularly interested in and that the company has pivoted to roughly about a year ago is to narrow some of the portfolio and say, we're particularly interested in this connection between research and care. If you've been following any of the literature, those things have been sort of approaching one another over the past 10, 15 years or so. If you think on the research side, FDA and others now are saying it's not really good enough to release your drug into the marketplace. We want to know what happens post-release, so post-phase 4 trials, for example, to know what happens when your drug gets into the wild. Now, there's some pretty prominent examples of those things going badly. I'm old enough to remember Voltaren, which was a great anti-inflammatory drug until it started giving people heart attacks. And so the framework of saying we need to know more is there on the research side. And then on the care delivery side, it's probably been about a decade since we've been talking about what a learning health system is. And this idea of saying that you can have a scenario where new discoveries sort of stay in the lab for decades before they reach common and broad clinical practice is really becoming more and more unacceptable. One of my early sort of moments as national coordinator, I've had the staff and I was talking to them about what is the time frame between discovery and implementation into sort of real world care. Because I had remembered as a med student in the late 80s that it's probably a 16, 17 year gap between a great new discovery and being able to go every place in the country. Me, I grew up outside of Fredericksburg, Virginia, so you could go to Fredericksburg and get that care. That distance in time from, down the street here at George Washington and then getting to Mary Washington Hospital in Fredericksburg, Virginia, is still about 16 or 17 years. So the problem still exists of how to make a new discovery part of sort of routine clinical care, and that's one of the areas that Verily's focus and leaning into. I will tell another I'll frame another problem for you and that we think is important to solve, and that's that healthcare's relationship with data is pretty poor. It's pretty poor. So you think about all the things that happen in terms of data gathering, data sharing. We often either have too much data that is not interpretable, not particularly structured well, not ready for study. There's nothing that makes me more anxious than hear somebody saying we're caring for people, we have their lives in our hands, but we cannot use that data, for example, for even the most minimal research purposes because the data is not good enough. And the fact of the matter is, it's poor data that's produced. And so one of the things that we're thinking about really deeply, and I think the industry needs to think more deeply about, is this sort of relationship that healthcare has with data. Being more deliberate about the kinds of data we collect, how we, the care with which we produce the data. Thinking about that beforehand, thinking about the ways that we analyze and put the data forward for some positive use as we think about the future, and then having this data and this effort be transparent. So none of those things work with the sort of black box sort of mentality around this analysis and work to be done. That's particularly true in the areas of AI, machine learning, and health equity. And I'm told that I should not throw stones at large national players in this mix, but you all probably know of a large electronic health vendor that has a prediction algorithm, an AI prediction algorithm for mortality in the hospital, but there is no insight as to how those attributes come together to do that prediction. You can subscribe to it, you can buy it as part of a module, but in our mind, there's a level of transparency about the AI that is necessary to develop trust in the communities in which it's deployed and to make sure that you're not inadvertently introducing disparities in care as you roll that forward. So for us, like the ideal scenario is a scenario where across our sort of products, you have something like an individual, we've sort of named this person Patricia for this illustration, that's using perhaps a population health management tool pretty broadly in use, and particularly in the administrative services only large employers across the country today. So they're using that tool, they're getting their care sort of oriented, they're doing better in that space. But they have an opportunity to participate in a disease registry. And as a component of participating in that registry, they can get, for example, a smart watch or a research grade watch that they wear. They can, in the All of Us, Verily and many others, Duke and other institutions are participating in the All of Us registry. They might contribute some genomic data if they choose to do so, all of this in a transparent way. That person then may subsequently be selected for a clinical trial. And in our cycle of research to care, an intervention that's proven to be successful might roll back into a standard routine care plan for an individual. That's not the world that we live in today, but it's clearly the world that we're trying to think about what's the right connection between research and care to go forward that really takes advantage of the data that exists. So I'm going to pivot for just a minute and talk about like why are we focused on the particular clinical areas that we're focused upon. And then I'll talk a little bit more about the use of AI and some health equity concepts. So, in this day and age where I had a little bit of palpitations when I got ready to get in my cab and I could not find my COVID mask that I still wear in the cab and on the airplane, in this day and age, it still is not particularly high on our list of what's really driving healthcare costs today. Even at the height of COVID, chronic disease, and heart disease in particular, was still the #1 killer of individuals in this country. So the point of this particular slide is to say two things. One is, it still is chronic disease where the attention is likely and should be paid if you're paying attention to what's driving the most morbidity and mortality across the country. If you're an insurance payer or CMS, that's where most of the cost is. And if you add oncology to that mix, those become super important areas for focus. Not that other areas are not of importance. In fact, we do work with wastewater analysis with some of our AI tools at Verily for COVID and other viruses. But I'm pointing out the fact that these are important areas to focus upon. The second thing, and the reason I find it super difficult to separate the work around health equity from work on things like chronic disease, is that still in America, you're 1.5 to 2 times more likely for an African American to have one of these chronic diseases. And if you're African American, you're more than twice as likely to die from diabetes complications than others in society. So it's really hard to think about driving this work forward if you're not taking a broad approach. You can't leave folks behind. The anecdote I tell a lot is I served as the CMO of a blues plan in Louisiana. And as you know, with Medicare Advantage, all health plans live and die if they're in that space based on how they drive their stars metrics quality for their populations of patients. That's how you live and die. So we had a little analysis, and I know it's Louisiana, which is, it's a browner state than most, but the fact of the matter was, we did not have enough plan members who lived in the Garden District to take their care level from a B to an A plus and raise our star level if we ignored the folks who were in New Orleans East and in the French Quarter. And the point of that is, if you're talking about the health of populations, you can't, in good conscience, leave populations behind if you're thinking about just moving the quality ball forward. That's not a left or right concept. That is not, I'm not preaching to you about morality. Right now, I'm just talking math. It's very hard to do well with populations and then ignore large segments of populations. So that's one of the reasons I think it's particularly important to have this framework. So this is the look across the country. And I'm not ignorant to the fact that there are GLP-1s around and people are drawing different curves for what obesity might look like in the future, et cetera. Still, given that, even if it's not 171 million people with chronic disease a few years from now, the fact of the matter is it's likely to be a large number of folks, and we need strategies to sort of approach this the push that's coming forward. And again, as I mentioned before, these numbers are worse if you're from communities of color, so you need strategies that work in particular. The other point I really want to make is it's not just the care of the disease. Often we just don't know enough about how to treat diseases in subpopulations within the country. So this particular example I'm sort of calling out is around these new molecular therapies, and this is a lot of the CAR-T and other work. If you look at that group is what's represented here. And if you can read across the slide yourself, those numbers don't look like the demographics of our country in terms of who's in the buckets and who's being studied. The larger House of Medicine numbers are actually worse. In the House of Medicine, if you talk about all research that's done, the numbers are more like 38% or so of the country is from communities of color, and somewhere between 5 and 7% of study participants are in this bucket. And so what does that mean from a healthcare perspective? I'll tell you one thing it means. It means we make mistakes. And so if you think about the many years that we treated pediatric patients with pulse oximeters, only to find out that your skin pigment changes by 1 or 2 points the reading of your pulse oximeter, it means that we did not study the population enough to know about the intervention that we were doing. And so there are, from the course of even when, and I remember as a resident when those technologies became more widely used, so in the past 40 years of medicine, we have underserved communities because we did not have the right data. So it's stuff we did not know based on the framework of the studies that were performed. So that's an important thing as we think about diversity. So I'm going to throw stones at another Silicon Valley company before I talk about the Biden executive order. But like one of my favorite AI mishaps, now it's a few years old, but it's around the facial recognition software strategies that were tried with AI. And so it worked really well if you were a 28-year-old white software engineer from Silicon Valley. It made no mistakes. It could tell John from Jim, and those things work really well. Turns out when they just sort of turned it on another random group, like Congress, it got many of the representatives of color confused and had poor outcomes in that space. And so what I'm referencing here is one of the things that we actually are focused in on and think we're good about this executive order, where HHS was charged in this executive order to think about safety profiles, and in particular to look at these AI algorithms as they're coming out to ensure and make sure that there weren't inadvertent advances and disparities in care that came out because of these algorithms that are being deployed. Another one that's pretty famous, and this is some of United published data in this space, was if you think about things like using AI as a predictor for acuity and who needs interventions, It turns out that medical spend is at best an average or poor proxy for someone's actual illness. Medical spend, which was one of the main drivers of that particular insurance algorithm, is related in part to whether or not you have insurance and whether or not you can manage your copay. So when they looked at outcomes based on the AI that was developed for picking who was going to get an intervention, there was a pretty big disparity in the communities that were overlooked because the AI algorithm pick people who are already receiving a fair bit of care. Now, in those subgroups, I'm confident that if everyone had the right, sort of the same amount of insurance, et cetera, then those numbers would have been good and that AI would have worked. But the point of the matter is, and we are on record at Alphabet in this, we think that this sort of approach that's sort of outlined in executive order, this construct that we need to be particularly attentive to the AI itself. It's not magic, it's math, as they say at Verily a fair bit, that you have to be careful about assuming that because it came out of the back end of an algorithm, that it is a perfect measure or perfect guide in this space. So we published a little bit of work on this. This is a paper about a year ago, I think it came out, where we were saying, like, if you're thinking about this from a research perspective, how should you think about approaching communities that are often underserved? How should you do design? What should your relationship be with communities? What should the approach be? And again, I'm trying my best to move across and past the platitudes. It's not like we care. It's like, what does your care equal? What are you going to do differently today in terms of your recruitment, your approach, your engagement, your long-term strategies to keep communities that are often left out of these studies engaged? And it's often an in-the-house as well as out-of-the-house phenomenon. So in the house, we often know that people sometimes decide, and this has been looked at several different large institutions, sometimes there's a bias in who is offered participation in the study. So if I take my sort of 2-minute glance, you might meet a lot of criteria. A lot of this is today, as you know, done in a face-to-face way. And I think that I'm not quite sure if you're going to come back and complete the study and make all the follow-up visits. I also have choices as I enroll people in study as those things go forward. And then many people have talked about the back end of that. If I'm the person that's being approached, do I have enough trust in you as an institution to engage with you in the study aspect? So those things I think are important as we frame these things going forward. And we laid out some of those items in the study. So I want to pivot just a little bit and talk some about, like, what do we think is a reasonable approach for companies across the country to take. I'm going to use what we did as a little bit of an example, but I think that there are many folks that are thinking deeply about this, and we've talked with some of the farmer sponsors in this way as well. So we started a Health Equity Center of Excellence that I lead, and I'll tell you a couple of things that I think are pillars here that are not often talked about. I think the first one is this idea of it requires a cultural change within the organization. And I think it's easier to talk about than to execute, to be frank. I mean, so let me point out a couple of different things. It is very easy for us to sit around the table and say, in a series of synonyms, that fairness and equality and equity and a sameness is an approach that we can all get behind. But the fact of the matter is, the minute we start talking about equity, we're talking about individuals, and we're not talking about sameness. And so even sometimes challenging the construct of fair within an organization is a tough road to hoe. And I'll tell you, on one end of the spectrum, it's pretty easy to talk about. So if I have two people and they both have coronary artery disease of a certain level as measured by some objective test, but I know that there's some factors and predictors, and for the person on the left-hand side, I say, you're going to have angioplasty, because that's the right thing for you based on some of these other miscellaneous factors. And for the other person, I say, you probably need coronary artery bypass graft surgery. There's not a line of people standing around saying, hey, you gave that person angioplasty and that person a bypass. It's well understood that there are other factors that may determine what is the right sort of prescription for person A versus person B. Move along that spectrum into care delivery strategies that are less black and white is where you sometimes get into trouble. So I'm an emergency medicine doc. We were often, as a resident, in the business of handing out the sort of the vaunted bus token for people who were in the department who needed to get home for some problem. How do you hand out the bus tokens? They have some monetary value. Do I make a judgment about whether or not I think you should be able to get a ride home? That's the conversation at the nursing desk. I actually saw them with a pack of cigarettes in their jacket. I think they can find their own way home versus me making another subjective judgment about who gets a bus token. It's even more anxiety provoking if you talk about compensation for participation in studies, for example. So one of the cultural things we think is that you have to come to grips as an institution about your framework on health equity. I think it's a concept that you can't do much of the additional work that we're going to talk about if you have not done some deep thinking about equity versus equality and how individual needs matter when you're trying to design the sort of work that we're talking about here going forward. We have changed the way we produce products. That's not an easy thing, as you can imagine, a software company, particularly a software company that grows out of a company that makes billions of dollars a year. People are pretty confident with how they do things. They don't want some short emergency medicine doctor wandering around giving them instructions about how they should think about life differently. But, it's the concept of saying, though, that if you design, for example, clinical trial management software in the exact same way, with the exact same concepts, with the exact same community approach, and you expect to have a different outcome than 5 or 7% of people in those communities participating, we think that's a bad framework. So I'll go through a couple of specific ideas that we put into play, but we've changed the way that software is developed within the company. We think that it's too big of a job to do as a solo institution, so we've tried to do partnerships with others. We handle software and solutions. There's a lot of last mile work that a lot of community organizations are doing. We don't have community health workers. We don't have other tools that are often proving by studies to be effective in sort of driving down these health inequities. And we think that this strategy about finding those folks and engaging with those folks is super important. This is sort of the roadmap. I'm not going to go into this in detail because I talked through many of these items, but I just want to sort of just highlight that, like one of the concepts under the software development. So I think you're probably all familiar with this concept of a focus group, and we would be far from the first Silicon Valley company that says you probably should look at a focus group before you're developing software to put in the marketplace. But we don't believe that that's really the definition of a collaborative design strategy. So when we're thinking about collaborative design, we're saying it's not 2 hours at the beginning of an 18-month process that produces software that's important here. We think that the complete redesign means that over the course of a software development cycle, in the same way that I bring in scores of user experience researchers and user experience design folks, I need to be in front of patients who might use this tool along the development software pathway. So it's relatively new for us. We have just finished our first 3 months. I just was looking at some of the data about our patient advisory panel, we're calling it, a participant advisory panel. This is from African-American men and women, actually mostly women in this case, that are post-cancer survivors that we're engaging in for the development of our oncology solution. But the construct there is weekly engagement over the course, paid, by the way, paid weekly engagement over the course, because we respect their time, paid weekly engagement over the course of 12 weeks. And they're not just sort of saying, I wish I had an app that did X, Y, Z. It's the same kind of input that you would get from a user experience design person, which says, like, if the button's up here, I won't use it, or I feel devalued if you ask me the same set of questions in the same way over and over again. And I'll say one other thing about like what that means in practice. It means in practice, there's no, when you open up a Verily app, there's no like, here's a black man button, push that button. There's no function that looks like that. I want to be really clear about what this means. If you have a scenario, for example, where you find that, I'll use a specific example that has been also reported in literature. Often you'll find that some communities do not have the same relationship with what behavioral scientists call the voice of authority. So if I'm developing software and I think that I have a group that responds to the voice of authority, what are the first few links and interventions I make? Well, I put a connection to the CDC. I have a picture of a doctor in a prominent institution downtown speaking. I have a whole lot of areas that touch on the voice of authority. If I know that the voice of authority does not work in a certain community, and it's more the community connection that works, instead of building a lot of links out to people giving speeches, I build links out to other community members. I create social networks as my first development in the path of the software. So it's really going back and saying what used to be number 11 on a list of 10 things that we can afford to develop for our MVP release. I move 11 to 3, and I make sure that if I want to address a community that's been left behind, I rank highly some of the elements that I find from my participant advisory panels. We think that's where the emphasis should change and shift. So I just want to make sure that that's really the way to think about that last piece. I have a few more specific concepts, and then I want to share a couple of examples with you. So we talked a little bit about the product inclusivity approach. As an Alphabet spinoff, you can imagine most of the goals that we get are around not making just sure that your tool can be used in South San Francisco. People expect at some point it's going to show up in Frankfurt and Mumbai. So the construct there is that as you're doing the product requirements documents, you need to think more broadly about who might use the software and what the barriers may be for those who are trying to use those. We talked a little bit about the AI and ML algorithms. I would say one of the really important concepts of those ML AI algorithms is that you don't find things that you do not look for. So one of the examples I'll show you a little later is around not being afraid to segregate your data and to look at subgroups of individuals. We went for 20 years saying that we want to be a colorblind healthcare society. There are a lot of instances where people don't ask. But if I don't ask, I don't know if I have any disparities of care. I don't know if there are any differences in outcomes if I've not even sort of framed my data up for that look at some point in the process. We pay attention to behavioral science in this space. I used to give a lecture, I would say people are people, which is a kind of a corny way of saying it, but we know, for example, that all of us in this room have a bias toward the present. That's just the way we're built as people. So if I come to you and I say, you should do this important thing for your health, because 40 years from now, you might have a toe that gets amputated. It does not resonate. And it doesn't matter that the second thing that I tell, or the other approach is sort of like more of a shoulder shrug. If I say to you, if you don't manage your diabetes well, if you don't manage your diet well, you're going to be the worst looking person at your 30th year reunion next year. Unfortunately, because people are people, behavioral science issues do play out here. So part of the construct of motivational interviewing, what drives individuals, needs to be built in your software structure. It's an important concept there. And then the last thing I'll say about this culturally competent care is, again, it's not like, there's not like hip slang in the Verily software stack, right? That I'm going to try to appeal to the 50-year-old black man because I'm going to say something that resonates in a particular set of phrases. But there are certain cultural approaches that people think are important. So for us, some of the straightforward things are, we are really careful about our pronoun use in our app. We're really careful about how we address communities and how we sort of put our questions in a place that we think are respectful, and we test those in marketplaces. If you don't test those in marketplaces, you don't know what those effects are going to be. And I will promise you, I joke about this all the time. Our average age of our entire team right now is 28 and a half. And we have a predominance of engineers in the company, about 800 engineers out of the 1,200 folks. And so if you design all of your outputs based on what a 28-year-old software engineer thinks about the world, you will not have a process or a product that's sort of like appealing to the folks that we're all trying to help across the spectrum. So we think those culturally competent concepts are important. And then the last thing I'll sort of peg is that we believe that, and I know you've had some discussions about like the government's role in this, et cetera. And I've learned this the hard way across my career. I'm determined that our company is going to swim with the current and not against the current. And so I don't think we have a problem with the standards. The question is, how are we going to like play in that space and move in the direction? And I do think, for us at least, the OMB framework on how to look at different communities we think is helpful. And then even since I was a national coordinator, this approach to a FHIR-based data stream we think is right. Now, I've known ever since we had this conversation that there are other HL frameworks that are used in different places, and I've certainly have people told me over my time as national coordinator that I was in the business of ruining medicine and trying to push people out of their comfort from a standard perspective. But we sort of think swimming with the stream and having the majority of us being able to share information in this particular way is an important part of this. So what does that mean from a couple of specific examples? I'll just give a few of these and I'll close for discussion or maybe an early lunch or whatever the plan is. So a couple of these. One is, this is back to this concept of not being afraid to ask and find out about the individual. And I will point out to you that one of the things that's new today, say versus 30, 40 years ago, is we have enough technical prowess and computing power to make these efforts an N of one. And so as we're collecting and stratifying, you see in the middle like a version of the usual healthcare pyramid on a population where you're trying to take a limited amount of resources and put them across a large group. And you're trying to stratify to know who will respond best to an intervention. One of the ways that you know that is actually with this concept of stratification. We think that that's a super important framework in this space, and we think you get to this individual personalized care plan by looking at these data sets, doing the red analysis, and then tying that back to a learning health system framework going forward. We have a solution that we have put in the market that does this work. I won't sort of go into sales mode, but the underlying concept of this is this concept of motivational interviewing. So we collect data about what people want to work on. We frame it in a way that we're talking about what's important today, not just what's important 40 years from now. And then we try to make people make the approach more about the person and not the disease. People don't view themselves as a disease. And so when we're talking about chronic condition strategies, so hypertension and diabetes or like our main example, we want to make sure that it is a person approach and that we are knowledgeable across those two items. And you don't get 4 messages about eating well because you have 4 chronic conditions where it's important to eat well. That's another construct there. I want to go just a little bit into a specific example with, this is with the University of Pennsylvania around this culturally competent approach. And this is another one of those lessons in hubris, I guess, or lessons that were taught about humility. We, in the beginning efforts of COVID, we partnered with UPenn on a bot approach because essentially they were overwhelmed in all of their call centers. They did not have enough capacity as people were asking questions about COVID, et cetera. So we had a matched algorithm and then an AI framework behind that, which is to say we started out with about 17 or 18 basic questions and answer pairs. We used a large language model from Google Cloud to help us figure out what an individual was saying, and then we actually provided responses. And then there's a parallel program that this paper is about where we also had this present in a text message format. And so on the one hand, I think that we, at the beginning of this, we were particularly successful in trying to drive down the traffic and allowing people to take calls and care for folks who were otherwise would have been on hold forever. What we learned, though, is that the multimodal approach was probably the key. And there were places in the Philadelphia catchment area where the uptake was near zero on staying in the queue and doing the call, and they only responded well to people on the telephone. And what I think that taught us as a company is that it's not that we lost any leverage in working with Penn on how you can use these technologies. It's the fact that for certain frameworks, certain cultural outreaches, certain communities, you have to be able to go down to an N of one, what's important to this individual. And at that point in time, there were sections of the catchment area at Penn that really did not respond to the generic, but responded to the specific. And so the second version of these had more of a multimodal approach because tech isn't always the answer for all of those solutions. And then another example I want to talk with you about that I'm particularly proud of is this other idea about how do we solicit and tap into folks who are often not participating in trials, not using the clinical outreach that we've designed for them. So before I talk with you about, this is the multi-bandit structure. I was looking at non-medical papers in preparation for the talk, and the multi-armed bandit has papers from almost, not quite, but almost a decade ago, used in non-medical areas for deciding what to present to you as an individual. And I won't quiz the group because you'll probably guess right away, but one of the earlier spots for this was streaming music. So I think my wife and I have similar tastes until I look at what's on her Spotify feed. We clearly do not have exactly the same taste. And the point of that is they're using the construct of a randomized multi-armed bandit. So we have a paper that we have that's coming out that takes that similar approach from a healthcare perspective. And if you know about how that technology structure works, what you're doing in those bandits is it's not an A/B test. You know, that's tech from 30 years ago. It is a multifactorial test where you can balance for different items. Okay, so what's the use that we're talking about here? The use we're talking about here is in clinical studies. So in the past, there are only two variables that were important for sponsors in studies. Money, how much does it cost to recruit the right number of people, and time, how fast can they be recruited? So that's two dimensions that you can optimize for in your outreach, and that's been done for years. What we're proposing here is that you add a third to this and you frame it as a Markov decision model and use a multi-armed bandit approach to say, we're also going to optimize for equity. So what does that look like on the ground? So the old approach is you say, okay, so we're in Washington, D.C. You say, black men in Washington, D.C. like WHUR. It's got the quiet storm, or used to have the quiet storm when I lived here. It's basically, you know, that is the place that we're going to advertise to get our N high in the group. So you buy data, and sponsor organizations buy data. They decide on their spend before the study, and they distribute their spend where they think they're likely to get the right outcome. What we're suggesting in this construct of this multi-armed bandit is I make a guess, maybe I even start with the same guess. I make a guess at what I need to do to get my projected target of individuals, but I use the multi-armed bandit to make me better as the study goes. And so in practice, what you do is you go to your intake folks and you say, we're gonna spend 20% of our marketing dollars for this study now. We're gonna make a study within a study, and we're going to change the channels around which we recruit for studies in order to get to the target items. So if you look at a lot of the clinical studies, the goals that are enumerated are the right goals. They'll say, for example, if we have a disease that has X percentage of African Americans, for example, in the target group, that's what we're going to hope to get in our study group. Like if that's the epidemiology of the disease out here, this is what we want in our study group. But they fall short. The idea of this framework that we're putting forward is you actually use adjustments during the study. And so one of the first places we've deployed it is with a skin health study with L'Oreal. Yes, that L'Oreal, if you're wondering. And the approach there, and it's from people outside, a group of women outside of New York and outside of Dallas. We're hoping to get 1,000 African-American women in this particular study. But the approach we're using there is we're changing the channels, including messaging, to dial up or down based on what's happening versus what we thought would happen at the beginning of the study. So we're about halfway through the study. I don't have the final results to share with you. Obviously, we're hoping that our strategy here works, but this rank and approach is important. The other place we think it's important is really just in healthcare delivery more broadly. And what I'll say to you there is the current triage and distribution of services in healthcare is not optimized for need. I'm saying the obvious, but I'll say it one more time. So who gets into the necessary dermatology visit in Washington, D.C.? Who gets in? If you're super persistent and you call every day and you bug somebody, maybe you get in a little bit earlier. If, by the way, you're down the hallway from the chief medical officer who, whatever, did some contract negotiation, or if you know somebody from a dinner party, you get in. The construct now is based on who can cross the threshold for care. And one of the models that we're really focused on here is a population-based model, where the approach then is if I've done my segregation and I have a target based on that slide, a slide or two ago with the pyramid of care, how do I optimize outreach to make sure the people who are in trouble get in the door? And that also means an unequal distribution model of advertising and outreach. It's back to my comment about New Orleans East versus the Garden District in New Orleans. Like if I know I can run as many breast cancer screening campaigns as I want. If I've already got 80% of the people who are targeted in the Garden District, another blast ad is maybe gets me 2 or 3% more, but it doesn't take my 20% number in New Orleans East up to even a C grade number. And so this construct of saying we're going to take a proactive approach as opposed to who just comes through the door and use science around how we do our spend. And yes, spend is an important part of healthcare activity, advertisement. Do you know where you get what services, et cetera? That's another item that we're pushing for that we think is another construct that would be good in this space. I've talked about this one a little bit already. This is just another framing on it. This is about the pediatric. This particular study is around the pulse oximetry. I talked about that a little bit earlier. Just to underscore that this is this construct of be careful if you're not doing equitable science, you're often doing bad science, and you'll go for decades in a situation like that. I want to talk a little bit more about the approach for studies and screening tools and how important that is. So this is a retinal camera. It's for retinal screening. It's one of the Verily product offerings. But what I want to talk with you about is something that is relatively, well, it might be known in this audience, but it's relatively unknown, say, across the country, which is that this concept of macular pigmentation of the optic area in the eye is different in racial groups across the world. And it may not be what you expect it to be. So the darkest or the most dense macular pigment, the macular pigment density is the highest in Asia and South Asia. And it's much less dense in the folks of African descent and folks of Northern European descent. So one of the things that we had to do on our first version of the camera, so the first version of the camera is just what you think it might be. It's and I love the video, but it's a typical Silicon Valley video. It's got like 8 software engineers in a row sitting down and demonstrating how easy it is to use the camera, which is good. It's an important step, right? Like if you're going to see if the thing works, you might try on your buddy who's sitting next to you in the cubicle. But the point I'm trying to make here is that it was never going to be rated for prime time until we tested across a broader spectrum of individuals. So we ended up with a partnership in South Asia, and about 40,000 individuals were trained on the AI algorithm before we thought it was ready enough to bring the product to market. And that's to say that, again, if we treat this the way that the pulse oximeter was treated 3 decades ago, you're at risk for developing a product that is unable to detect the differences in diabetic retinopathy without sort of these nuanced differences in individuals. And again, this is one of those examples where it's not your skin color, it's really the density of pigmentation on your optic area, or retina of your eye. So anyway, that's another take-home point there. And this is the other point that I was making about measurement. The measurement point I'm making is just that you cannot put your head in the sand. And so I will tell you that the usual approaches would be a little less likely to look at the output of our study watches in this way. But we were advocating that we push, as we think about AI and machine learning and testing these algorithms, you do need to look. If you do not look, you will not find. Now, this particular one is not dramatic. It's our real data, but it's not dramatic. But as you can see, the segmentation into Asian, Black, white, other races is something that in the past has made companies like Alphabet a little squeamish. But one of the things that we're pushing really hard is if you don't look for differences and nuances, that you won't find them. So that's a fundamental change, I think, in the way that we're thinking about this aspect of medicine more generally. So I'm going to close with just one story. Maybe it's a set of stories. So I don't fundamentally view this as an exercise in morality. I myself consider myself a moral person. I would feel bad if this was not something that we put as important for us, but I don't consider it simply a matter of what is the right thing to do. I think we often think about this as an effort and sacrifice. So if I'm thinking about health equity as I'm bringing solutions to market, I'm sacrificing something. But I want to argue with you is some of our most successful interventions were built with a framework of saying these things need to work for everybody. And often when these things work for everybody, they lift all boats. You've often heard people talk about not joining in studies, for example, because what does joining in a study means? It means they have to drive downtown, find a place to park on Thursday morning, get a 10 a.m. blood draw for the next 6 weeks, et cetera. And so those things sort of are barriers. But my point is that if you make it a digital, easier experience for folks who cannot drive in, cannot take off on Thursday, it often gets better for all people. So these are two of my favorite examples. If you are like me and you rolled your suitcase here for something, you'll notice that everybody with a big, heavy suitcase is using the curbside cutouts. Everybody is. Curbside cutouts, clearly were designed as part of a response to the ADA. That act required that you make things more accessible than they were otherwise. They'd done time and motion studies in cities, and by far the largest users of those conveniences are people who are not in wheelchairs. It's the guy that's rolling the Coca-Cola rack of things, or the Heineken thing to the bar, or you rolling your suitcase down the street. It's been something that's been good for society, and we all have benefited from an inclusive design. The second one I like to talk with my kids about because it's the origin of text messaging, which was really designed initially for those who are hard of hearing. I do not need to tell you who uses text messaging now. Everybody in here has probably texted during this lecture, but the point of the matter is that this concept of inclusive design is not, should, in my opinion, should not be viewed as a penalty for the work that we do. I think that an equitable approach to the use of machine learning and AI in healthcare is an approach that will help us all. So I thank you for the chance to talk to you guys about this topic, and I guess if there's any questions, I'd be happy to take one or two, but thank you for your time. Thank you.
We welcome questions here in DC as well as virtually through the Zoom chat. We'll first go to DC.
This is a great presentation.
Oh, thank you.
I found it really insightful in a couple different ways. One of them in particular, you mentioned how the software incentivizes the right motivation. It can change depending on the population.
Yeah.
What occurs to me is that equity is sort of on a gradient. Depends on how much you put in is how much you get back out. And small businesses that don't have the capital to invest in that research, really novel research, what advice do you have for them where they can still build innovative products using AI but don't have the resources to put in all of this expertise and subject matter knowledge to be able to build that software? Are there open source libraries they can use, or what kind of resources do they have?
Yeah, that's a great question. I have two sort of approaches generally. In the area of health equity specifically, I feel like the urge is to do all that needs to be done. That's sort of the initial impulse that people have. And a lot of times, even in the work that we're trying to do as an Alphabet spinoff company, do what's proximate. So it's not a bad thing to work on the elements that you have levers to, because we all have some contribution to make in this particular space. So in my mind, as we're often pushed when there's some big catastrophic newsworthy event that happens and people want to make company statements about something or make a comment about something that we're not directly involved in. If it's police violence or something, like there's this urge to do this thing. In my mind, it's do what's proximate. So there's things that happen, and unfortunately healthcare is sort of a target-rich environment in this space. Back to your specific question, though, I do believe as we're going down this pathway, there are more and more both open source and items that are available for folks to sort of engage in. I think Having talked to some of my HHS buddies, I think that there are toolkits that will be sort of out frequently. At Alphabet, we put some principled and some framework statements out that are for the public, both in terms of AI. We have an AI statement that we've made sort of as an entire company. And then the last thing I'll say is that often what we're talking about is measurement and framework as opposed to doing something completely different. It's sort of adding an element or dimension that's often left out. But I do think it, the amount of what I would call sort of initial and broad research might be different based on the size and intensity of the organization. I think that's a given. But I'd say if you're interested, do what's proximate, and I think that'll be a great contribution. That's a good question. Thank you.
From the Zoom chat, a lot of folks are looking at AI and automation and increased use of portals/apps to solve things like scheduling issues, but that can have significant equity issues, visually impaired individuals, et cetera. How do you balance the desire to make and take advantage of technical advancements with the equity challenges some of them bring?
Yeah, I love this question. If you have a measurement-informed structure to your software development, all of us who are in this space have elements that you have to meet before you're past design and you're release ready. There's some release cadence that you have to perform. So in my mind, if you are producing, for example, a scheduling software program, and you find that it is introducing an equity, is it ready for use? Like, is it ready for the work that you've designed it to do? So for us, we have a large language model chatbot that we're in the process of doing some second and third versionings of. And part of our release cycle requirement is it has to pass our health equity framework before it gets released out the door. And I don't think it's an acceptable framework to say this thing increased our productivity, but severely worsened the disparities in the communities that we're trying to serve. It's an element, just like there are other safety elements. And I'll tell you one other part that we did change, which I think is in that framework that I'm particularly proud of. You probably are all aware, you cannot release a health-related software product today that has below 9 font print. You can't release one that cannot be used by someone who's red, green, colorblind. They're accessibility standards. And what we're doing in our development pathway is we're also making equity standards for the release of product. And I think that's where I would like to plant the flag. And look, I'm sure that there's probably engineers today that are grumbling about having to change the color scheme on their user experience platform because if someone's red, green, colorblind, they can't read it. But that's just the world we live in. That's the way we produce software, and I think that's the framework. That's the right framework for something like an efficiency that has an untoward effect. I appreciate the time to indulge my passion on this. Thank you guys for the opportunity.